I apologize in advance for all lacking information that you might be missing, because it was a great challenge for me to throw out the slides yesterday evening when I realized that I have only 20 minutes. So for coming 20 minutes, I will cover, obviously, cholestasis in pregnancy and IBD in pregnancy. But I can't resist to very briefly touch upon the immunological changes during pregnancy, as my great teacher was always teaching me in biology that you have, when it comes to immunology, you have 3 sexes, 3 genders, male, female, and a pregnant female. And it's a very, very specific state that I will try to give you some novel information on the immunological landscape of the pregnancy. And then I can't leave out the legal aspects of the care for pregnant patients, because it's a very specific clinical situation. And I think every now and then, every one of us will deal with a pregnant patient. And we need to take into account much more legal aspects than we do usually in our clinical practice. So to start with, for those of you who treat transplant patients, you for sure realize how difficult it is to let the human body to accept a foreign body for many months. And pregnancy, it's just a physiological state that is doing it for 9 months, and it's doing it sustainably without any harm to the mother and to the fetus. And for many years, actually, for a century, the paradigm of this very specific immunological state was the barrier concept. So it was actually thought that the child is locked with the placenta, and those 2 immune systems, they are perfectly isolated. So it was thought like the mother's immune system actually does not see the baby, does not see that there is a foreign body in the maternal body. But this concept has changed, and there has been a tremendous amount of evidence for the last decades of the 20th century that elegantly showed that this is not a barrier process. This is a very active process of the maternal immune system selecting the embryo, selecting that genetic material which will be actually worth investing the coming next months the whole organism of the mother into the development of it. And those elegant studies, which dates actually back to 80s, they might not be considered ethical today anymore, but they show that actually post-coitally, you have already a very active immunological landscape in the endometrium with active influx of Th1 lymphocytes and regulatory lymphocytes, and that embryonic implantation is actually a tightly regulated process in which the maternal immune system is really actively choosing which embryo will be implanted and which will be, let's say, very, very roughly rejected. And when we looked at our data, which we were actually interested from the other point of view, we wanted to see whether vedolizumab, use of vedolizumab, the anti-integrin molecule, might interfere anyhow with the pregnancy outcomes. So we checked for the MEDCAM1 expression in the placenta, and as you can see, during the first trimester, the MEDCAM1 is highly expressed, although in mature placenta, you don't see any adenosine molecules. For those of you who are not familiar with this receptor, this is a very specific receptor by which the organ-specific lymphocytes are entering the organ. So if there is this uniform expression, and these are data from, I think, 20 or 21 placentas from the first trimester compared to 20 of mature placentas from the delivered placentas. So you see these data were very robust, and these expressions is stable in the first trimester. So if you have this high expression, that's just one surrogate marker telling us that it is very important to have this access of lymphocytes to the placenta, and this is a process that we might highly interfere with, or through the pathology that occurs during pregnancy, or through the drugs that we have to give our patients who become pregnant in a state of chronic disorder, such as IBD, for instance. So we desperately need to have some information about the safety of the drugs that we are using to treat our patients during pregnancy. And this is just briefly show you, I'm sure you are aware of this concept, every SPC contains this information, and it's the Food and Drug Administration rating for the very specific situation, the safety of the drug during pregnancy, which you can imagine it's highly unreliable as data, because who would dare to do a controlled study on the safety in a pregnant woman? Nobody. So these data are actually being drafted or drained from registries or from animal studies, and we show a nice picture how animal studies and human studies are actually very difficult to be extrapolated, animal data to be extrapolated to human data. So this first situation that you see, it's the FDA category A, which would say you have, so they are animal data available, so you gave the drug to 100 mice, and they became pregnant and they delivered healthy small mice, babies, I don't know how to call it, and you have given the drug to the humans, and the babies are fine. So there is none of the drugs that we are using in hepatology or in GI pathologies belongs to this category. The next is the category B, which actually means there are no human data, or they are in favor of the use of the drug, so there are no signals that the drug might be dangerous during pregnancy, and you have or positive animal data, or you have negative animal data, which means negative in this sense means there are some proven harms in the animal studies with the drug. So it's the situation or either, right? So you have or human data which are in favor and which kind of overrule the animal data, or you have no human data and animal data are in favor of the use of drugs. So the only drug used in hepatology is UDCA that we have at our disposal. Then it comes to category C, which means you have no controlled human data, you have negative animal data, or you have no data at all. So you see most of the drugs that we use and we have to use, they belong to this category. Then the last category, which belongs to MMF, is the category, both categories showed actually negative data, but the benefit that you have from using the drug during pregnancy outweighs the risk, so you are allowed to use the drug. And the last one is, you have the negative data, so it's the same situation, but you have an alternative, and you should be using the alternative if you have it at your disposal. So this is the FDA rating, which you might appreciate is very well based just on the data of the safety. There is nothing taken into account about the necessity of using the particular drug during pregnancy because of the pathology that the woman has, and she's using the drug for that specific pathology. And as I will come to back to this with the topic of IBD, we just can't afford not to treat our patients. So even if we are in the category C and D, we must proceed further. So let's come specific. I hope this will work. No, it's not working. So there is supposed to be a picture here, but it's just a decoration picture, so I'm sorry, you will miss it. But it was showing actually these three categories that we can encounter when it comes to liver disease during pregnancy. Liver disease can complicate approximately up to 3% of the pregnancies, and they are pre-existent liver disease, and they are de novo liver disease developed during pregnancy when that healthy pregnant women get sick. And I was given the trust to cover the topic of cholestasis in pregnancy, which mainly cover these two, intrahepatic cholestasis of pregnancy and acute fatty liver of pregnancy. This was the picture. I'm sorry, I deprived you of at the beginning. So cholestasis of pregnancy, let's start with the more benign one. It's the disorder of the intrahepatic bile flow. It's usually presents in the third trimester, and it can start with the very typical pruritus of the palms and feet. There is no jaundice, no urticaria, and the typical feature, laboratory feature, is elevated bile acids. There might be elevated transaminases as well. The pathology, etiopathogenesis, is somehow vague, speaking about hormonal trigger in a genetically susceptible woman, which is kind of obvious. It carries a slightly elevated risk of premature delivery, but it has a very good prognosis for the mother. It has been associated with pre-eclampsia, and it has a very quick resolution postpartum. Treatment is recommended in this dose of UDCA. There have been some benefits showed for mother, but there is unclear benefit for the child. And as I said, the prognosis is very good, in contrast to acute fatty liver of pregnancy, which is really a medical emergency and should be recognized very quickly. It's very rare though, so every one of us, if we are not working in a very specialized center, we might not encounter this case during our medical life at all, or we just see one or two. Those who are, of course, working in the liver transplant center, they see this on a quite regular basis. But the recognition actually belongs to the general obstetric outpatient clinics, because the presentation is very unspecific. It starts somewhere around 28 weeks, so somewhere in the third trimester, and it starts very unspecific. Which pregnant woman doesn't have headache, is not nauseous sometimes, it's not fatigued. So it's very difficult to recognize it in a timely fashion, but then there is a very rapid worsening with development of liver failure, and then there should be actually the alarm bell ringing with referring this patient to a center which has a good obstetric care and which has good hepatology care, preferably transplant center. The diagnosis is not that difficult, but it's very difficult to recognize it timely. These are the criteria that were proposed to be used. They have a very high negative predictive value, so if you are afraid that your patient has acute fatty liver and you have less than 6 of these criteria, I highly recommend reading this paper. There's a very nice overview of acute fatty liver of pregnancy with all these aspects covered. If you have less than 6 of these criteria, then there is a very high chance, very high negative predictive value, out of some studies 100%. On the other hand, the positive predictive value is somewhere around 85%. So when we summarize all the conditions that are coming into the differential diagnosis of these 2 cholestatic conditions, then you see the overview of acute fatty liver, HELP, preeclampsia, and intrahepatic cholestasis of pregnancy. These are I think quite clearly distinguishable from each other, and the management is different, so it's important, again, to stress that it should be concentrated in the center where there is expertise with this care. So what about IBD in pregnancy? These were those pregnant women who were healthy and who got cholestasis or acute fatty liver. IBD is a very different topic. It's a chronic disorder that we just can't afford not to treat throughout the pregnancy. We, a few years ago, generated this review that I would actually call everything you ever wanted to ask about pregnancy and IBD and you didn't dare to ask. Then read this. It's freely available on the ECHO website. I'm sorry that you can see there at the bottom. And it's written with clear statements for each drug use and for each situation. Because I can't cover the whole topic of IBD during pregnancy in this presentation, and I just want to pick out 2 points. One is When these two are combined, so pregnancy and active IBD, it doesn't matter whether it's Crohn's disease or ulcerative colitis, although ulcerative colitis, active UC and pregnancy still can mean death for the mother, so it should be treated very aggressively and again in specialized centra. So what can you get from this association? Very unfavorable outcomes for the child, low birth weight and preterm birth, abortion, but also intrauterine death. But in the worst case, especially for ulcerative colitis, urgent colectomy, C-section, or even maternal death, still in 21st century, from now and then you encounter these sad stories. So this is not something we can just chat about with the patient and say, oh, okay, don't take the drug, it's fine. When the ulcerative colitis kicks off during pregnancy, it can end up in a very bad situation. This is just a landmark study from this study. During the last 10 years, there have been many other studies confirming this. Active Crohn's disease, active UC, reduce nearly by half the favorable outcome of the pregnancy. So it's treatment of the disease which is crucial. And when you look at the FDA rating, because you have a pregnant patient who is on some drugs, the FDA rating is not very nice to us, to doctors treating these patients, because it doesn't give you a lot of support, especially in the legal forensic actions. So that's why we decided in the ECHO initiative, in that review in those guidelines that I showed you, that I alluded to create a slightly different categorization of the use of the drugs, IBD drugs during pregnancy, which takes into account more specifically the need for treatment. So it's not only the data that are available on the safety, but it's the need and it's the disease itself which is actually pushing you to treat the woman, and the benefit outweighs the risk in this instance. The last aspect, last slide, legal aspects, please. Everybody knows it. We care for 2 individual lives. It's a very difficult discussion. We have a pregnant woman with the disease that is treated, by several different specialists. So you deal necessarily with the obstetrician, you deal with the neonatologist, and many times with many different other specialists, radiologists who doesn't want to do the CT, etc., etc. You need to communicate on on everyday basis very clearly with your colleagues, but also with the patient, and to report this communication in your medical reporting, because when it comes to unfavorable outcomes and the woman comes to you and will tell you, you killed my baby because you forced me to use the azathioprine during the pregnancy, it's all about what is written in the medical report, about your discussion with the lady that will support your case at the court. So please, dear chairs, I hope I stick up to the time, and I'm sorry for not covering everything. Let me proceed to the conclusions. Pregnant woman gets sick, which is the case of cholestasis, and intrahepatic cholestasis and fatty liver are two diseases on the opposite spectrum of the prognosis of these 2 conditions. Timely recognition is crucial for both of them. Prognosis is influenced by you, by your timely decision. When a sick woman, especially IBD woman, gets pregnant, active disease is incompatible with favorable pregnancy outcome. We should keep this in mind, and we should repeat it to our patients and to our colleagues. It's my experience, gynecologists, obstetricians, they don't like the medication, and most of the drugs that we use are low risk. We decided to use this term, low risk, and not speaking about safe, because speaking about safe during pregnancy is quite risky and unclear, so we did the category low risk and high risk. And the effective medication that is keeping the disease under control should not be stopped when a woman is planning pregnancy. It's a multidisciplinary job when we are all one doctor, and we should see it like this, and we should coach our patients throughout the pregnancy as one person, all of us together. Thank you very much for your attention.
Thanks very much, Zuzana, for your nice lecture. We have time for 1 or 2 questions from floors. Which cholestatic liver disease is most frequent in pregnant ladies in your clinical practice?
Yeah, intrahepatic.
Yeah, intrahepatic cholestasis.
Yeah, for sure.
Another one? No one? Oh, no questions. Thank you very much.